Hello, my name is Dan Hertz. I'm an assistant professor at the University of Michigan College of Pharmacy. Thank you for attending my talk today on pretreatment Dpyd testing to prevent severe fluoropyrimidine toxicity. So just as a quick background, there are two drugs in the fluoropyrimidine class. The first is an IV agent called 5-fluorouracil, and the second is an oral prodrug called capecitabine. These drugs are commonly used in several different solid tumors, as I have listed there. Like most chemotherapy, use of these agents is associated with several different toxicities that can be very severe and can be perhaps fatal in some patients. On the right-hand side of this slide, you'll see the breakdown of the pharmacology of this agent with 5-fluorouracil in the middle. 5-fluorouracil goes down one metabolic pathway to FD-UMP, which is responsible for the efficacy of this drug. An alternative pathway they can go down is seen here in red. So about approximately 80% of systemic 5-FU goes down this metabolic pathway, where it is metabolized to an inactive form by hydropyrimidine dehydrogenase. This enzyme is encoded by the Dpyd gene. Over many years of research, we have found that there are recurrent polymorphisms of Dpyd that reduce the activity of Dpd enzyme. Here I have listed 5 of the recurrent polymorphisms that have been highly validated to reduce activity. You can see I have highlighted here in red some of the common names, although there are many different aliases that we use to describe these different polymorphisms. Each of these polymorphisms is found at relatively low allele frequency, as you can see all the way on the right-hand side. However, the combined carrier frequency is approximately 6% in Caucasians, and about 1 in 300 patients are homozygous for these variants. There are, of course, many other rare or singleton variants that have been reported to be low or diminished activity, but these 5 are the main that have been validated and are found in many patients. This next slide just shows a little bit of the consequences of these low-activity Dpyd polymorphisms. On the left-hand side, you can see a figure showing the decrease in Dpd metabolic activity in an ex vivo screen. In the top row, you'll see that in 121 samples from non-carriers, their Dpd activity ranged from a median of a little over 200. Below that, you'll see the activity in 13 carriers of the STAR2A and in 2 carriers of the STAR13 that have much lower Dpd activity. On the right-hand side, you'll see a comparison of the systemic 5-fluorouracil exposure in a single index patient who's a STAR2A carrier. That's indicated by the diamonds, and that is in comparison to 6 control patients who are shown in the triangle. You can see the one patient with the diamonds has much higher 5-FU concentrations and much prolonged concentrations relative to the control patients, showing that carriers of this STAR2A polymorphism or other low-activity polymorphisms have increased systemic exposure to 5-fluorouracil. That increase in systemic exposure is now known to be affiliated with an increase in severe toxicity. There have been many studies, and I'll show you some of those on the next slide, but this is one of the largest and best studies. This is a retrospective analysis conducted in a prospective clinical trial called NCCTG N0147. This trial had almost 3,000 patients with colon cancer who received standard combination chemotherapy, including 5-fluorouracil. These patients were genotyped for Dpyd STAR2A and D949V, 2 of the well-established low-activity polymorphisms. The primary outcome in this analysis was severe grade 3+ 5-fluorouracil-related toxicity or adverse events. You can see on the bottom left the results for the Dpyd STAR2A carriers who had a near 90% risk of severe toxicity compared with about 30% in non-carriers for an odds ratio over 15. Below that are the results for the D949V carriers, showing again about an 80% risk of severe toxicity versus about 30% in the non-carriers with an odds ratio of approximately 9. You can see on the right-hand side these results were consistent across all major subgroups and these results are consistent with what has been seen in several other cohorts. Here's a study that just showed a meta-analysis for 4 of the major validated variants. So you can see in the upper left-hand corner the Dpyd star2a, then going around clockwise the star13, HAPB3, and D949V. In each case, these variants were associated with a statistically significant increase in severe toxicity, with adjusted relative risks between an increase of about 60% for HAPB3 to a 4-fold or higher increase for star13. Of course, those have relatively wide confidence intervals because of the small numbers of patients, but each of these analyses had at least 4,000 patients in them, or highly statistically significant. In addition to the increase in severe toxicity, we also know that there's an increase in fatal toxicity in carriers of Dpyd variants. So I have here several reports in major medical journals of case reports of individual patients who passed away of treatment or later found out to be carriers of a Dpyd polymorphism. These have been somewhat repeatedly reported, unfortunately, and there are some well-known stories and websites that are dedicated to patient stories who were treated with standard dose of fluoropyrimidines and passed away or had severe toxicity before finding out that they were Dpyd carriers. A recent analysis indicates that the risk of fatal toxicity in a Dpyd variant carrier is approximately 3% when given standard fluoropyrimidine dosing. In addition to all these retrospective reports and retrospective analyses, there are now prospective clinical studies that demonstrate the benefit of preemptive or pre-treatment Dpyd testing. This is a prospective single-arm trial of greater than 1,600 patients who were pre-treatment tested for Dpyd star2a. Based on their star2a genotype, they received either standard dose fluoropyrimidine if they were wild, an empiric 50% dose reduction if they carried 1 copy, or an 85% dose reduction if they carried 2 copies of the star2a variant. They were then dose escalated in future cycles of treatment as tolerated, which is consistent with the dosing guidelines. These patients who were pre-treatment genotyped for star2a were compared with a historical control of Dpyd star2a carriers who were not genotyped prior to treatment and who received standard dosing. This comparison was made to demonstrate the benefits of pre-treatment testing. There is also a comparison of the star2a patients who received adjusted dosing versus the wild-type patients who received standard dosing, so we could see some of the potential risks of dose adjustment. And finally, there was an analysis of healthcare costs, and I'll show you the results of these studies in the next slide. So in the primary analysis, looking at the star2a carriers who received adjusted dosing, compared with a historical control of star2a carriers who received standard dosing, there was a significant reduction of grade 3 plus toxicity from about 73% in the historical control to about 30% in the dose-adjusted group, with a p-value of less than 0.001. That shows you the benefit of dose adjustment in star2a carriers. There was additionally a nominal reduction in toxicity-related death from a 10% estimate to 0%, although this did not reach statistical significance due to the low number of events. Again, there were also some secondary analyses to look at the risks of dose adjustment. Specifically, the grade 3 plus toxicity in our star2a carriers who received adjusted dosing was compared with our grade 3 plus toxicity in our non-carriers, so our wild-type patients who received standard dosing. And you can see a normalization of toxicity of about 25% in each group. There was also a normalization of drug concentrations, indicating that these patients, the star2a carriers who receive adjusted dosing, should have normalized efficacy as well, although that was an analysis done in this publication. Finally, in their economic analysis, they estimated that Dpyd screening prior to treatment saves about $60 per patient. This data and other similar data from other studies has led to a publication by the Clinical Pharmacogenetics Implementation Consortium, or CPIC, describing their recommended dosing for patients who carry Dpyd, who have known Dpyd genotype. So in the top row here, you see your normal metabolizers. That's a patient who has two normal alleles, who has normal Dpd activity and should use the label recommended dosing and administration. In the next row, this is a simplified version indicating that a patient who carries one no functional allele has decreased Dpd activity and should receive a dose reduction of about 50%, followed by escalation as tolerated. Finally, in the bottom row, our poor metabolizers who have no functional alleles have complete Dpd deficiency. They should either avoid use of fluoropyrimidines or empirically reduce the starting dose by about 90%, again followed by escalation as tolerated. And you can see the full CPIC dosing recommendations at the CPIC or PharmGKB websites. So now I'll just quickly go over what the general benefits and harms of pretreatment testing are, so everyone understands the benefits and risks of this strategy. So again, starting with the benefits of dose reduction, in our variant carriers, which is about 6% of patients, there is a reduction in grade 3+ toxicity from about 50 to 70% to about 30%, and a reduction in risk of death from about 3% to less than 1%. We believe there's an even greater decrease in the homozygous patients. However, precise estimates are currently unavailable. Of course, the benefits of dose reduction must be considered against the possible harms or risks of dose reduction. The first potential harm is the potential for decreased efficacy, particularly in the approximately 30% of Dpyd carriers who do not experience severe toxicity and were unnecessarily dose adjusted. We believe that there is a low concern for diminished efficacy for several reasons. The first is there are reports, as I presented earlier, that the drug concentrations and toxicity are normalized in the Dpyd variant carriers who receive dose adjustment. In addition, as I mentioned in the CPIC guidelines, the dosing guidelines recommend a dose escalation to tolerability after cycle 1, so all patients should receive their maximum tolerated dosing, as is usual with chemotherapy. A second potential harm that is sometimes discussed is this so-called false sense of security. There are about 30% of patients who are non-carriers of Dpyd variants who still experience severe toxicity from standard fluoropyrimidine dosing. We believe that there is a low concern for harm, or in fact, no harm done to these patients by genotyping. If you genotype these patients and there is no genetic variant found, this does not change their dosing or their monitoring in any way. Whether or not this patient received genotyping, they still would receive their standard fluoropyrimidine dosing, and they would still experience the severe toxicity, unfortunately. Finally, there's some concern for the overall cost of genotyping, particularly because of the somewhat low incidence of Dpyd variant carrying. As I showed before, there is some evidence that pre-treatment Dpyd testing actually saves money per patient in the range of about $50 per patient. This is due to the high treatment costs in Dpyd carriers who receive fluoropyrimidine dosing, which has been estimated to be greater than $2,000 per patient due to high risks of toxicity and hospitalization. I'll also note that there is a somewhat recently approved antidote for fluoropyrimidine overdosing, which is called uridine triacetate. That treatment costs about $80,000 per treatment. So you can see that even preventing a single case of having to use that drug makes this very financially viable. When we think about the evidence supporting pretreatment testing, we think about what is the evidence of clinical utility. So clinical utility is defined as the use of genetics to guide patient care improves treatment outcomes. I believe that I have presented the evidence showing that treatment outcomes are improved in our Dpyd variant carriers based on pretreatment genotyping. There are two ways to demonstrate clinical utility based on a report from the Institute of Medicine. The first is a retrospective analysis of a prospective clinical trial using archived specimens, and I showed you that in this study from the NCCTG. The second way is a prospective clinical trial in which the genetic test directs patient management, and I showed you that in the prospective genotyping study with a genotype Dpyd star 2A and demonstrated a reduction in severe toxicity. Therefore, I think that we have met the threshold of demonstrating clinical utility in both ways that are available, and we have clearly demonstrated the clinical benefit of pretreatment Dpyd testing in patients who are going to receive fluoropyrimidine treatment. Many groups have agreed that we have surpassed the threshold of clinical utility, and testing is now recommended throughout Europe. Testing for Dpyd or Dpd activity is required in France and the Netherlands, and over the course of 2020 has been recommended by many of the medical agencies in Europe, including the European Medicines Agency. However, in the United States, testing is not recommended by any major body, including the FDA, ASCO, or the Nccn. And currently, although we believe the frequency is unknown, although we believe that testing is uncommon, the frequency of testing in the United States is unknown. We did an internal survey at the University of Michigan of our medical oncologists to understand their practices and beliefs about Dpyd or Dpd testing. We asked this survey to 16 medical oncologists who use fluoropyrimidine, who mostly came from breast or GI oncology. Here's a histogram of the number of patients who these medical oncologists started on a new chemotherapy regimen that contained a fluoropyrimidine. So you can see that many of our oncologists use these agents in about 1 patient per month, whereas some of our medical oncologists use these agents in 10 or more patients per month. Our first question was, have our medical oncologists ever ordered a Dpyd or Dpd test prior to starting fluoropyrimidine chemotherapy? You can see that about 80% of our medical oncologists had never ordered a test prior to treatment, whereas about 20% had. We then asked of those medical oncologists who have ordered testing, how often they order testing and why. 2 of the oncologists, 2 out of the 3 who said they had ordered testing, said that they rarely do. 1 medical oncologist said that for selected patients, they order testing based on performance status. We then asked several questions about their beliefs about Dpyd genotype and the pretreatment testing. The first question, shown here in red on the right-hand side, is, do you agree with the statement that Dpd deficiency increases toxicity risk in patients treated with fluoropyrimidines? As you can see, most of our clinicians strongly agree with this statement. However, the next question, shown in the purple, was, do you agree with the statement that testing of Dpd or Dpyd is useful to inform treatment? And here you can see a much more normal distribution, with most medical oncologists in the middle saying they neither agree nor disagree with that statement. Only about a quarter of medical oncologists agreeing with the statement that pretreatment testing is useful. We then asked for about several factors that we believed might prevent medical oncologists from ordering testing, and I'll go through some of the major highlights. So the factor that was endorsed to be extremely or very important by most medical oncologists was the lack of clinical guidelines from any of the major guideline committees, as I mentioned earlier. The next most common response was the low prevalence of Dpd deficiency, followed by the potential concern for decreased efficacy from dose reduction. There were several other factors asked about that had much lower concern, including testing cost and a concern that Dpd testing will not reduce treatment toxicity. One final question we asked about was whether Dpd deficiency is actionable information. So here we asked, if you knew that your patient was Dpd deficient, what would you do with that information? You can see that none of our medical oncologists said that they would not do anything. Every medical oncologist said that this would be actionable information, with most saying they would decrease fluoropyrimidine dosing, or some saying that they would consult a clinical guideline to find out what to do with dosing, or switch to a non-fluoropyrimidine treatment. So you can see that when this information is known, it should definitely be used because it's actionable to guide treatment. So in conclusion, our survey confirms that Dpd deficiency is known and understood to increase toxicity risk. However, few individuals or few medical oncologists are ordering Dpd testing, mostly because of the lack of clinical guidelines. This survey has been approved for national distribution through SWOG, and we hope to have results in the near future. Now that we have demonstrated that there is an improvement in clinical care from pretreatment testing, I'll show you some of the work that we're doing to increase the amount of pretreatment testing that's being done. The current status is that few fluoropyrimidine-treated patients are tested prior to treatment. There are some sites and clinicians who I'm aware of that are ordering testing, and there are some advocate efforts to increase the patient awareness to ask for testing. One of the things that we've done at the University of Michigan Rogel Cancer Center is to use our existing Dpyd data to make sure that patients who have known Dpd deficiency are being treated accordingly. So we have a large program called the Michigan Genomics Initiative that it's a genetic data repository from greater than 60,000 patients who have genome-wide genotyping information. This information cannot be used for clinical decision-making. However, it can be used for clinical research. What we have done is we've set up a clinical research study that is essentially an implementation project where we have received the names of the approximately 3,000 patients who are known carriers of one of the 5 Dpyd variants based on this MGI data. We've set up automated alerts in our medical record, so anytime one of these Dpyd carriers is diagnosed with a fluoropyrimidine-treated tumor, our study team gets notified. We then contact the medical oncologist to confirm this patient is going to receive a fluoropyrimidine and enroll the patient on our study and order and pay for their confirmatory Dpyd testing through the Mayo Clinic. Upon confirming their Dpyd status, we return this information to the medical oncologist within the electronic medical record and provide them a dosing recommendation so that this patient can receive safe and effective dosing. We launched this study in September of 2020 and launched our automated alert system. We immediately found that there was a Dpyd carrier in the MGI data who had previously that week been newly diagnosed with colon cancer. We immediately contacted the medical oncologist and confirmed that this patient is expected to receive combination chemotherapy, including a 5-fluorouracil. We then enrolled the subject the following day and sent their Dpyd test and returned that information with the confirmed Dpyd Hep B3 carrier status to the medical oncologist within 7 days of launching our alert, demonstrating the efficiency and rapidity of getting this information for patients. In terms of the efficiency, it cost us $600 to identify and confirm one Dpyd variant carrier, compared with about $12,000 per Dpyd variant carrier identified in doing pre-treatment screening of all patients. We plan to expand this process to UGT1A1 and other genes that are actionable in patients with cancer. A much larger pool of patients could benefit if we added Dpyd to somatic and germline cancer genetic testing panels. This is a concept that I published on last year in the Journal of the National Comprehensive Cancer Network. So in terms of germline cancer panels, we know that many cancer patients undergo multi-gene germline testing to find cancer predisposition. According to the Nccn guidelines, all patients with pancreatic cancer and many patients with colorectal, breast, and ovarian cancer should receive some kind of germline testing. These are all tumors that are commonly treated with fluoropyrimidine treatment. The Nccn guidelines recommend multi-gene testing and specify that not all genes included on the panels are necessarily actionable. I would argue that Dpyd is actionable and should be included on these panels. There are some germline panels that do include Dpyd, including the panel from Color Genomics. However, others do not, including panels for germline genetic testing by Ambry and Invitae. We are very interested in working with these companies to add Dpyd to their existing panels. Similarly, there are many patients with cancer that undergo somatic or tumor genetic testing to select a targeted treatment. We believe that by adding Dpyd to these cancer genetic panels, we could achieve the benefits of Dpyd testing for limited additional cost. There are some tumor genetic panels, including that from Tempus, which also include germline testing and have included Dpyd. However, other commonly used panels, such as that from Foundation 1, are only tumor testing and do not include Dpyd. We are currently working with a foundation group to try to work with some of these companies to try to convince them to add Dpyd so patients can benefit from this information. Finally, we really hope to get to the point where all fluoropyrimidine-treated patients are genotyped for Dpyd prior to treatment. In order to do so, again, based on what we heard from medical oncologists, we need to get the guidelines panels on board with recommending fluoropyrimidine, Dpyd testing in patients who are going to receive a fluoropyrimidine. Specifically, we're interested in getting recommendations from the Nccn and/or the FDA. The Nccn treatment guidelines for colon cancer currently include the following quote. So the colon cancer guidelines state that individuals with variants of Dpyd have a significantly elevated risk for severe life-threatening toxicity, acknowledging the clinical validity or the increase in risk in these carriers. They go on to say that pre-treatment Dpyd testing showed a significant reduction in the risk of grade 3 toxicity, acknowledging the clinical utility of pre-treatment testing. They then conclude by saying that universal pre-treatment testing remains controversial and the NCCN panel does not support it at this time, despite acknowledging the clinical validity and clinical utility. We submitted a request in 2019 outlining some of the more recent data, recommending that germline Dpyd testing be added to the routine pre-treatment workup for all patients likely to receive a fluoropyrimidine, followed by dosing according to the CPIC, as I presented earlier. Their response was the panel did not support the inclusion of Dpyd testing as a routine component of the pre-treatment workup, and the final vote was unanimous of 0 to 22. They did not give us any reasoning for this. However, what we understand is that the NCCN guidelines are based on current clinical practice. So here we have a classic chicken and egg situation. So the clinician practice is not to order testing, and they say this is because of a lack of clinical guidelines from the NCCN. The NCCN does not update their guidelines to include testing because their guidelines reflect what happens in clinical practice. And here, neither group is ready to make this first step because they're waiting for the other to lead the way. We hope that one way to break this logjam is to get a recommendation from the FDA for pre-treatment Dpyd screening. So the FDA package inserts for 5-fluorouracil and capecitabine were updated in 2016 to acknowledge that patients with certain mutations in Dpyd are at increased risk for severe early onset toxicity that can be fatal, and that patients with partial Dpd activity may also have increased risk, which I showed you from earlier studies. In the patient counseling information of the package insert, it advises that patients should notify their healthcare provider if they have known Dpd deficiency. The issue is that patients would not know this prior to receiving a fluoropyrimidine. We have submitted a FDA citizen petition with Mr. Ken Serpinant, a well-known patient advocate for Dpyd testing, and several other leaders in this field. We recommended adding a black box warning for the toxicity risk and to recommend pre-treatment Dpd screening in patients who are going to receive fluoropyrimidine. We also requested that they recommend Dpd-guided dosing from CPIC or other such dosing guidelines. There's a QR code that you can scan with your phone so you can read our petition, and there is currently an open comment period so you can add supportive or not supportive comments to the FDA, changing the package insert to recommend pre-treatment testing. Thank you very much for attending my presentation. Here's that QR code if you'd like to comment on our FDA petition. We really would appreciate your support, and I look forward to answering any questions from the audience. Thank you very much.